Hi, my name is Dr. Andrew Stein, and I'm an internal medicine resident at the University of Florida. I'll be presenting a case report, vision loss in an adult with uncontrolled hypertension, increased intracranial pressure, and myelin-oligodendrocyte glycoprotein antibody disease. Myelin-oligodendrocyte glycoprotein antibody disease, or MOGAD, incidence is 0.16 per 100,000 per year. Idiopathic intracranial hypertension, referred to as IIH, another rare cause of acute vision loss, has an incidence of 0.9 to 1 per 100,000 in the general population. Hypertensive retinopathy is a more prevalent loss of vision etiology. We present the case of a patient who displayed components of all of the aforementioned pathologies at presentation. A 36-year-old African-American female with history of hypertension and morbid obesity presented to our facility for acute bilateral vision loss, eye redness, and pain with eye movements. On initial ophthalmologic examination, her visual acuity was light perception in the right eye and no light in the left. Her intraocular pressures, or IOP, were mildly elevated at 24 and 27 mmHg in the right and left eye, respectively. Both pupils were dilated and non-reactive on pupillary exam, and dilated fundus examination showed bilateral grade 3 optic disc edema and tortuous vasculature. She also had elevated systolic blood pressure of 220 mmHg. A non-contrast CT scan of the head suggested underlying intracranial hypertension with a mildly expanded, partially empty cella and signs of bilateral optic hydrops with optic disc edema as seen in Figure 1. Brimonidine and timolol were initiated for elevated IOP, and her hypertension was eventually controlled with hydrochlorothiazide, labetalol, and amlodipine. Further evaluation with MRI revealed bilateral optic neuritis and left thalamus and midbrain focal lesions. Figure 2 demonstrates the left thalamic lesion, while Figures 3 to 6 show different MRI windows of her optic neuritis. IV methylprednisolone was started, and subsequent lumbar puncture demonstrated an elevated opening pressure of 39 mmHg with unremarkable cell count. Acetazolamide was initiated, and the opening pressures 3 days later was 21 mmHg. For complete workup, MR venography ruled out central venous sinus thrombosis, and head and neck CT angiogram ruled out dural fistula. She was discharged with a diagnosis of IIH and hypertensive retinopathy and continued on acetazolamide. The aquaporin 4 antibody lab was negative, and other labs pending, and visual acuity had improved to 20/400 in the right eye and count fingers in her left eye. Weeks later, the MOG antibody returned positive, confirming a diagnosis of MOGAD. Rituximab was initiated, leading to complete resolution of optic disc edema and almost full recovery of visual acuity. There has since been no recurrence at 1-year follow-up. This is the first reported case of MOGAD with IIH in an adult. MOGAD is recently recognized inflammatory demyelinating CNS disease similar to neuromyelitis, optic spectrum disorder, and multiple sclerosis. MOGAD's defining feature is a positive serum MOG antibody with other characteristics including optic disc edema and more extensive CNS involvement. Bilateral optic neuritis is the most common presenting feature, and the disease course is either monophasic or relapsing, with the strongest predictor of disability being transverse myelitis. MRI frequently shows enhancement of the anterior optic nerve and sheath and adjacent orbital fat, and CSF findings can include pleocytosis and raised protein. IIH is classically found in overweight females in their 4th decade of life. It is characterized by increased ICP of at least 25 mmHg with unknown cause in the absence of space-occupying lesion, venous thrombosis, or meningeal disease. A recent study of 34 patients with IIH found no evidence of MOGAD or aquaporin 4 antibodies. Hypertensive retinopathy, acute or chronic, is perhaps the most common contributor to vision loss, with an incidence of 66% in the general population and 83% in those with hypertension. Hypertensive emergency presents in 2% of the hypertensive population, with risk factors of female gender, obesity, and medication noncompliance. If blood pressure is decreased too rapidly, or there's an increased intracranial hypertension, optic nerve ischemia can occur. Our patient's acute vision loss was most likely multifactorial, fitting diagnostic criteria for all of the above pathologies, with good response to their associated treatments including steroids, acetazolamide, and antihypertensives. This case presents a unique presentation of acute vision loss influenced by multiple underlying pathologies. MOGAD is a rare disease and has not yet been reported in conjunction with IIH and hypertensive retinopathy. We demonstrate the importance of a broad workup in acute vision loss and treating all suspected contributing etiologies. Thank you for listening.